talking about bronchial asthma and pneumonia today. I think we still have ischemic heart disease, the acute coronary syndrome pending. But since we'll have a presentation on that, we'll do that next week. It'll be relatively easier to do that in class. So we'll do that next week. So we'll be talking about bronchial asthma. We'll try and define and see the types, and usually the pathogenesis relating to the whole asthma, the common etiology, and of course, precipitating factors. If your patient has got asthma, how would you be able to detect the asthma? We'll talk about that and possibly look at some investigations, even though asthma is a diagnosis of your clinical features. There are some other investigations that you can do to support your diagnosis, and then we'll manage asthma because you would be having a lot of asthmatic cases coming to you, both at the OPD and then the ER. You should know how to pick them up and then manage. So asthma tends to be a chronic inflammatory condition, okay? And once we talk about asthma, when you take the airway, you breathe in, it goes all through the nasopharynx and all that, and gets to the trachea. From the trachea, it gets to the bronchus, okay? The left and right bronchus. And this area is what we are going to focus on. The bronchus is the area we are focusing on. So what is happening is that inside this bronchus, just like any other part of your body, it comes with various parts, okay? So inside the bronchus, or from inside to out of the bronchus, you have the mucosa, okay, or the inner lining. And then you have a middle layer where you have more of smooth muscle. Then you go to the outside layer of the bronchus, okay? So the changes you are going to see in a patient who has asthma is going to occur inside the bronchus itself. So we are talking about the mucosa, and then the layer of cells under the bronchus, where you are talking about the lamina propria and then the smooth muscle cells. This would undergo some change, and the change you would undergo would eventually lead to your airway becoming narrower, your airway becoming hyper-responsive, okay, and your airway becoming inflamed. And basically, that is what asthma is all about. So once we talk about asthma, we are not talking about a condition of the alveoli. We are not talking about a condition of the bronchioles or a condition of the trachea. Our focus is on the bronchus, left and right bronchus, okay? And the changes that would occur in this bronchus is what is going to trigger the features that we'll be talking about soon. So the symptoms of asthma would usually result from one, a limitation of airflow, okay? So because you've gotten some sort of structural change in the mucosa of the bronchus and in the smooth muscle layer of the bronchus, because of that structural change, your airway is going to become narrower, and this is going to limit the airflow that is going in. There's going to be some sort of restriction to the air that you expect to go through the bronchus, the bronchioles, and get to the alveoli. That's one. Also, you are going to see some sort of hyper-responsiveness, meaning that the inflammatory cells over there in the bronchus would react so much that you would have the features of inflammation. And one of the features of inflammation is that you are going to see what we call exudation or exudates, meaning you are going to have a lot of secretions being produced inside the bronchus. And of course, these secretions would also impair air moving through the bronchus and getting into the alveoli. Okay. So basically, that's what asthma is based on. In classifying asthma, we've got two types. We have extrinsic asthma and intrinsic asthma. So what is extrinsic asthma? Extrinsic asthma is the common type of asthma we see when we go and do our locum, when we're young, and then we say, oh, our young friends have asthma and all that. That is extrinsic type of asthma. And as the name suggests, extrinsic means that you can put your finger or place your finger on some sort of external trigger. Okay, so the trigger could be dust, the trigger could be a strong scented perfume. Extrinsic asthma, you've got some sort of trigger, induced inflammation, okay? And the process of the inflammation is what is going to result in airway hyperresponsiveness and an occlusion of your bronchus. Unlike extrinsic, once you talk about intrinsic, as the name suggests, usually you are unable to pick up a trigger there and then. Okay, intrinsic asthma, you would usually not pick up a trigger there and then saying that, oh, the person has got infection, so the infection is triggered an asthma. No, intrinsic asthma would usually start in midlife. So that is what we call late onset of asthma or adult onset of asthma. What is happening here is that a person who was basically born not having any family history of asthma would grow up developing symptoms of asthma because this person, during the person's lifetime, would have ended up working in a particular company where he's gotten exposed to certain chemicals, certain dust and all that. At that point where the person was exposed to the chemicals and the dust, such stuff didn't trigger any asthmatic experience. But with time, when the person grows up, these things that the person has been exposed to in previous, like in the past life, would be causing changes in the lungs. So once the person grows up, it tends to affect the bronchus. And then the person will start having a narrow bronchus and start showing symptoms of asthma when he goes through a certain trigger like stress, poor sleep, and all that. Okay, so that's the difference. Extrinsic here is common in children. Intrinsic starts in adulthood. With extrinsic, you're able to place your finger on an external trigger, which there and then causes bronchial hyperresponsiveness. With intrinsic, you don't have that kind of external trigger. The patient would have been exposed to these triggers when he was young, and as he goes up, this exposure causes a change in the bronchus and then gradually causes the bronchus to become narrower. The pathogenesis of asthma is all about inflammation. Okay, once you understand inflammation, you would get the pathogenesis of asthma. And remember, we said there are some cardinal signs of inflammation where inflammation will come with pain, inflammation will come with redness, inflammation will come with exudation, which will lead to swelling and all that. In this case, the focus here is on the exudation. Okay, so what is happening is that there's an external trigger, and this external trigger is going to induce your inflammatory cells. The induction of the inflammatory cells is what would eventually lead to the production of excess secretion in your airways. And once you've got excess secretion in your airways, breathing becomes difficult. Okay, so when you take the bronchus, as I said, you've got the mucosa. The mucosa is lined with cells, goblet cells, that ideally produces some form of mucus and all that to prevent infection. Okay. And then under the mucosa, you have your smooth muscle. But in between this mucosal cells and then the smooth muscle, there's a layer of cell called the lamina propria. Okay. So just like when you take a muscle and then on top of the muscle, you have what we call fascia. When you are focusing on the bronchus, you have an inner layer, and then after the inner layer, there's a middle layer. The inner layer here is what contains the cells and all that, the columnar cells. Then the middle layer is where you have your smooth muscles, the muscles that will usually constrict to cause bronchoconstriction or relax to cause bronchodilation. And in between the inner layer or the inner mucosa and then the middle layer, there's another layer called the lamina propria. And this is a layer of connective tissue. Okay, so it's like a concrete between the mucosa and then the muscular layer. This lamina propria contains a lot of cells. Okay, it contains what we call mast cells. And if you should go back to physiology, you know that mast cells contain a substance called histamine. And whenever mast cells are activated and histamine is released, there's some sort of allergic reaction being produced. Most of the allergic reactions we tend to see is secondary to histamine release. And that's why we give antihistamines such as cetirizine in allergic reactions. Whenever a mast cell is activated, histamine is released, and then this histamine release will trigger an allergic reaction. Everybody has mast cells in this lamina propria, or this layer between the mucosa and then the smooth muscle. But in asthmatics, the mast cells are a lot than a non-asthmatic person. They've got a lot of mast cells there. So as soon as there's an allergen, maybe some sort of infection or cockroach, dander, or pollen, as soon as this allergen is getting into the blood, your body makes your IgE, which is an immunoglobulin E, which is responsible for allergic reaction. The IgE is going to bind to this allergen. And then once it binds, you are going to have something like an antibody antigen complex. Okay. So it binds, and this IgE and then the trigger complex will go land on the mucosa of your lungs. Okay. In this case, the bronchus. Once it lands on the mucosa, it's going to trigger a reaction which will lead to an activation of the mast cells. Okay. It leads to an activation of the mast cells. And then because this trigger and IgE is also going to trigger inflammation, apart from the mast cells that it will trigger, it would also recruit a lot of inflammatory cells, the neutrophils and all that. Once the mast cell is activated, as I said, you are going to release a lot of histamine. The histamine is going to cause an allergic reaction where you have a lot of secretions being produced into the cavity of the bronchus or into the airway. And once you have the secretions being produced, it's going to, one, block airflow and cause airflow limitation. Another thing that will also happen is once this allergic response starts, you are going to have the smooth muscle contracting, and this smooth muscle contraction will lead towards bronchoconstriction, which will further decrease the caliber of your bronchus and cause you to have airflow limitation, and hence there will be reduction of air moving through the bronchus into the alveoli, and that is what would bring the person to the hospital, because once you have air unable to get into the alveoli, you're going to have difficulty in breathing. Okay. Any questions with the pathophysiology before we move on?
Hello, sir. Good morning.
Yeah, good morning, Achu.
Yeah, please. You said people with asthma, they have a lot of mast cells in the lamina propria.
Yeah.
Is it the fact that they have the mast cells there, that is why they have that strong reaction, or they have been exposed to some that cause the mast cells to be more there?
All right. Okay. So that's a good one. So when we move to the next slide, you'll realize that the same etiopathogenesis slide, you would see something called atopy. Okay.
Yeah.
So sometimes it's more of, and that's why when you're taking a history of asthma, you would want to ask about a family history. Sometimes it's more of a family history, and once you've got a family history of asthma, some people are born with like some sort of, they've got lots of mast cells. Okay, so they easily produce a lot of histamine, which would trigger reactions. Some people too have should I say an overactive or hyperactive response when it comes to stuff binding to their mast cells, and hence they tend to make a lot of histamine. So sometimes you go in, you realize that there's a genetic factor to it, and that's why, or should I say hereditary factor to it. That's why family history is very important when you are dealing with asthma. Okay. So that's it. The other aspect to it is more of a vicious cycle. One, you might have a family history which will trigger, which will cause you to have lots of mast cells, leading to your excess secretion of histamine. At the same time, once an inflammatory response is set in, your body naturally makes lots of mast cells. And that is where the second part of your question comes in. Is it that they become a bit sensitized to the trigger? So as soon as they have it, then you start making, yes. So the mast cell is produced in your bone marrow. So even though because of your genetic predisposition, you might have more mast cells or hyperactive mast cells, whenever it's triggered, your body becomes sensitized to the trigger, and your body makes more mast cells. Your bone marrow makes more mast cells in preparation for the next trigger that will come in. You get it?
Yes.
So that's how it works. So it goes two ways.
So it means that some people's asthma will be as a result of family history, and others will be just because they have constant exposure.
Yes. So to the trigger, and even that if you are talking about children, there's a constant exposure to the trigger and there's a family history there. But if you take the family history out and there's a constant exposure to the trigger, and the asthma doesn't start, and it starts in adulthood, where at that point there's actually no exposure to the trigger, then you say this has become an intrinsic asthma. Okay. All right. Yeah, Foster, you've got a question. Yes. Yeah, Foster.
Yes, sir. Good morning, sir.
Good morning.
Yes, sir. Mine is on the classifications, sir.
Yeah.
About the extrinsic and the intrinsic. You said the extrinsic is as a result of a trigger.
Yeah.
Right. Okay. But with the intrinsic, you were saying that it is as of maybe a result of an occupational hazard, and with time,
exactly.
Yes, you develop the symptoms, and that's when we are exposed to maybe stress and poor sleep, right?
Yes.
Yes. So can we say that with the exposure to those stress and those poor sleep, are they not a risk factor to that intrinsic classification?
So I think the stress and the poor sleep here becomes an extrinsic factor.
Yes, will trigger the intrinsic, right?
It will trigger the intrinsic, yes.
Yes. if I heard you well, you said something like that with the intrinsic is as a result of occupational hazard, and with time, if it goes through over and over again, you are exposed to it, you start showing symptoms when there is stress and poor sleep.
Yeah.
Yes.
Yeah. Oh no, land.
Yes. So I was saying that the stress, those and poor sleep that you said, is it not also as a sort of risk factors to the intrinsic, as the extrinsic is as sort of a result of perfume and the dust and pollen?
All right. Okay. So that's a good one. So what is happening here is you can say that even though the intrinsic factor, we don't expect to pick up a classic external feature. Our focus here is on what we call an allergen. Okay. So what differentiates this is you can't say that exercise is an allergen or stress is an allergen or weather condition is an allergen. You can't say that.
Okay.
You get it. So yes, so the intrinsic would usually, as I said, would usually pick it up in adulthood. And this is not because at that point in time where you are getting the asthma, the person has been exposed to an allergen. An allergen is like from pollen, house dust mites, cockroach dander, fur and those things. It's not because the person has been exposed to an allergen, but rather the trigger at that point is a non-allergic trigger like stress, emotional destabilization, weather changes, poor sleep.
Yes, sir.
Okay. And before this non-allergic trigger can work, the patient should have had a certain condition in the past which has caused some sort of lung changes. Because without that, we are all exposed to stress, poor weather condition, poor sleep, but we don't get a trigger because when you go back into our history, we don't have that kind of exposure to the occupational stuff or the chemicals and all that. So we don't have a previous exposure. So even when we are stressed, we might not have any trigger of that sort.
Okay, sir.
So what will make it easier is you just say with external or extrinsic asthma. With extrinsic asthma, you are dealing with an allergen, but with an intrinsic asthma, the other name is actually non-allergic asthma. Okay, so that is what will differentiate it.
Yes, sir. Thank you, sir.
You're welcome.
Sir.
Yes,
sir,
please.
With the pathogenesis, some of us we just had difficult joining. So please, if you can, throw more light on it, because I was join it. Yes. Thank you.
Okay, you're welcome. So with the etiopathogenesis, maybe I should have put a picture of a cut surface of the bronchus in there. But yes, so once you are looking at a bronchus that has been cut in a coronal section, you are looking at it in a round area like that. You've got an internal layer, you've got a middle layer, and you've got an external layer. Okay, just like most organs in the body. So the internal layer over here has what we call the columnar epithelium. Okay, and this columnar epithelium also has some cells we call goblet cells. We expect that it will produce mucus to protect the lining of the mucosa. But when you are producing too much mucus, then it becomes a negative thing to the bronchus, because too much mucus means it's going to block the pipe holes, should I put it that way. But ideally, it's supposed to produce something small, some mucus to protect the inner lining of the mucosa, because we are constantly exposed to harsh environmental conditions. Then under this mucosa, you have your smooth muscle. And this smooth muscle is what is responsible for bronchoconstriction, bronchodilation, depending on the stimulation you have. Okay. And I said between the mucosa and this middle smooth muscle layer, you have another layer which lies in the middle there. It's between the mucosa and then the smooth muscle. And this layer is what we call the lamina propria. And the lamina propria is where you find the inflammatory cells. So everybody has got a lamina propria. And this lamina propria, you have what we call mast cells there. Okay. And apart from the mast cells, you also have your neutrophils and all that. In the case of asthma, I said the mast cells tend to be much more than what you have in a non-asthmatic person. That's one. And the mast cells are more sensitive, okay, to stimulation. That's two. So what is going to happen is that for you to develop an asthma, this etiopathogenesis is based on the common type of asthma we see. That's the extrinsic type. For you to develop an asthma, we need you to have an allergen. This allergen here is the external trigger. And what happens is once the allergen gets into your system, usually through inhalation. So let person plays with his cat or dog and inhales the fur. The fur goes into the body through an inhalational route, and then the body senses it as an allergen and produces IgE, immunoglobulin E. And if you remember your immunoglobulins, we said IgE is responsible for allergic reaction. So it produces the IgE. And just like you are able to get antigen antibody complexes, this IgE will bind to the allergen. Okay, so it's like you have an antigen antibody complex. And whenever you have an antigen antibody complex, it goes to land or to settle on a certain part of the body. So the allergen IgE complex we have here binds to the mucosal surface and then triggers a response which would go and stimulate your mast cells. Okay, so your mast cells will now feel the presence of this IgE allergen complex and make what's histamine. The histamine ideally is what's stabilized in the mast cell, but as soon as you have an IgE allergen complex binding to it, it becomes what destabilized, and then you release a lot of histamine. This histamine, when released, is basically the basis of the allergic reaction, because the histamine will cause changes. You're going to have excess secretion from the mucosal cells. So the bronchus is now going to become, you've got like excess mucus secretion there, which is going to prevent airflow from the trachea and all the way down to the alveoli. Okay, so your patient's going to have difficulty in breathing. At the same time, this inflammatory response is going to cause you to have some sort of bronchoconstriction, whereby the smooth muscles in the middle layer becomes constricted. And this would also contribute to the closure of the lumen of the bronchus. Okay. Eventually, with time, and then a repeated exposure to this allergen IgE complex and histamine, the smooth muscle will become hypertrophied. So in asthmatic patients, you have what we call smooth muscle hypertrophy. And hypertrophy means that it becomes thick, big, and then it narrows the space of the bronchus, and hence there's airflow limitation. Okay. Are we okay?
Yes, sir. So you mean histamine is being triggered as a result of IgE allergic mast cell complex?
IgE allergen, yes, complex acting on the mast cell.
Okay.
The histamine, you're welcome. The histamine is stored in the mast cell, okay, and forms the basis of the whole inflammatory process in asthma. I mean, of course, eventually you are going to have because the histamine is being released and all that, they are going to have recruitment of other cells like the T lymphocytes. And that's how come asthma becomes more chronic, because when it's just acute, you are looking at neutrophils, but once it's becoming chronic, then you have lymphocytes coming in, okay? So eventually, you are going to have an inflammation, an acute inflammation, a chronic inflammation. You're going to have a lot of T lymphocytes and all that eventually, okay?
Yes, sir.
All right. Okay, good. So the precipitating factors, we've talked about a lot of them. So usually you've got allergens, and this is what we tend to find in extrinsic. So house dust mites, cockroach dropping, pollen, grass, fur, these are allergens, okay? Environmental factors like dust, air pollution, and all that could also be a trigger in both extrinsic and intrinsic. Respiratory tract infections, exercise, emotions, and all that, and your NSAIDs too. What we know is that your NSAIDs, as the name suggests, would affect prostaglandin synthesis, and prostaglandin is a very, very important substance which helps in anti-inflammation, basically. Prostaglandin would also help you protect the how should I even put it? Prostaglandin will help in the production of mucus and all that. Prostaglandin also has an effect on bronchodilation. So if you are given an NSAID, and this NSAID, we know that is going to affect the COX pathway, and the COX pathway is what will lead to the production of prostaglandins. So you take NSAID, it affects the COX pathway, and you have little or no prostaglandins produced, then it means that that protective effect the prostaglandin gives you, you are going to lose that. And then your airway is going to become narrower, which would make your asthma worse. Okay, so that's why we have to avoid NSAIDs in asthmatic patients. Beta blockers, I talked about it in class the other day, that non-selective beta blockers, so like propranolol, labetalol, they'll block both the heart and then the lung. And once they block the lung, they cause a bronchoconstriction. And this will lead to narrowing of your lumen of your bronchus, which would make airflow limitation possible. Your clinical features of asthma, I mean, I'm sure we all know your patients will usually come to you coughing. The cough, unless there's a secondary bacterial infection, the cough is usually a dry one. Then there's difficulty in breathing. They tell you the chest feels tight, okay? And if you have a patient who usually comes in the night with these symptoms, it means the patient has uncontrolled symptoms. Patients who have uncontrolled asthma would usually have nocturnal symptoms. It means as soon as the weather gets cold at night, the asthma is triggered. This is a sign of an uncontrolled disease. Then your clinical features in terms of signs, what you would see. So you would realize that when